So we have completed the laser enucleation and by single lobe technique and unidirectional en bloc enucleation technique developed at IUKD by me. So where we start the enucleation at 5 o'clock position and we do the enucleation reverse after putting early mucosal release. We start enucleating in the plane at 5 o'clock position and enter the bladder at around 3 o'clock position. After that, we enucleate towards the bladder neck and then we enucleate the lobe towards the roof. And after that, what happens, the advantage of the unidirectional en bloc technique is that the weight of the adenoma which gradually falls down and guide us during the most difficult position in the right side of the patient. That is the most difficult position for a right-handed surgeon, in the 9 to 11 o'clock position. But here, when we do a single lobe enucleation unidirectional en bloc, at that point the adenoma guides the proper enucleation plane between the adenoma and the surgical capsule. So we have completed, and as you can see that there is no blood, no bleeding at all. So we could see the single lobe adenoma inside the urinary bladder. So now we will do the morcellation. For morcellation, we have 3 different techniques. One is Wolf Piranha, that is toothed rotating type of morcellator. Then Lumenis Vat, which is one of the earliest morcellator to be developed, that is oscillating technique. And Kullstor's drill cut, that is toothed oscillating, and Lumenis Vat is non-toothed guillotine technique. So among the 3, the injury to the bladder is maximum in Lumenis Vat, but the instrument malfunction is less in Vat. So if we see the ease of doing morcellation, so the Lumenis is having little more bladder injury. So the Wolf Piranha technique, that is toothed rotating, is the most easiest to perform. Kullstor's drill cut technique is the movement of the adenoma while doing the morcellation is a little high, so it oscillates very fast, and the opening of the blade is little wider in Kullstor's drill cut. So the saline required for the similar size of prostate to enucleate will be almost double the number of a Piranha kind of a morcellator. So in morcellation, if Piranha, you need 3 liter normal saline to complete the procedure. In the Kullstor's drill cut, that is toothed oscillating, you may need around 8 to 10. So that way you can save some money for the patient. So before doing, now I am inserting the blade inside. Before doing morcellation, you need to ensure a few things, like you have to completely do a hemostasis. As you can see here, I have specifically dedicated around 5 to 7 minutes time to completely pinpoint coagulation of the bleeding vessels. So so that helps, and it gives you a clear picture, and that is because you know that if bladder mucosa comes and it may injure the bladder mucosa very fast, so you need a clear vision. After that, you ensure proper over distension of the bladder. You keep the bladder over distended all the time. So you deput one sister or a technician to put his or her hand just at the suprapubic region to ensure that bladder is full all the time during the morcellation technique. So after that, you adjust the suction pressure. Here I am keeping at 5, so that should be good enough. And inflow should be in 2 channels. You can put the saline like here, and here. In three channels you can put the inflow, or a single inflow with some pressure, and outflow should be closed, and here the bladder is over distended. Here we go with the morcellation technique. First, you have to go beneath the tissue and engage. You partially press the foot pedal. Here you can see that you partially place the foot pedal, and that engages the adenoma. You can see here inside that the way I have engaged. Now show me the monitor. I have engaged I have engaged the adenoma. You can see, you ensure that you have not sucked in some of the bladder mucosa by moving it to and fro, side to side. So now I'll start. You can see that this movement, the side to side movement in tooth rotating type of morcellation is mandatory. All the time you have to see that it is moving. So by accident, if you suck some of the bladder mucosa, immediately the lumen will collapse and you will not be able to see the adenoma the way I am seeing, and the free movement will be hampered. Now you can see that it is moving side to side. So it should be moving side to side all the time. And here you have to put again, you have to ask some sister or technician to ensure that the bladder is over distended all the time. Now you can see that the morcellation is nearly complete. Now if there are some cottonal kind of tissue which moves and sometimes difficult to engage, here you can see that smaller tissues are there which will come out. If a little bigger cottonal kind of adenoma which moves, then what you can do, you can just block the inflow, and then the movement will stop and it will be still, and you can like go nearby and partially press the foot pedal so that it sucks in the tissue. So now you can see that we have completed the morcellation here, and there is no injury to the bladder anywhere. So the prerequisite for a safe morcellation is proper hemostasis, over distended bladder all the time, and you have to see the movement of the blade like this. So the tip of the morcellator blade should be under vision all the time. And once you engage it, you come a bit backward towards the neck of the bladder, where the bladder wall will be almost fixed all around. So the bladder wall will not come easily to be sucked in the morcellation blade. So you engage, come back towards the bladder neck and press the outside assembly downwards so that it moves up and it goes towards the center of the bladder lumen. Thank you.